Good afternoon, our dear students. Today we continue lectures about internal medicine with endocrinology, and today we finish endocrinological cycle of lectures. And our today's topic it is disorders of hypothalamic-pituitary system. After it, according to your schedule, I'll continue upload lectures about another disciplines, another ways of internal medicine, but they will be from another teachers of our department. And before I start today's lecture, I am going to discuss with you USMLE tests from the previous lectures and correct answers. Please, I don't want to read it one more time. I hope you remember something, if not the text on the video. And what about correct answers? Test 1, correct answer 4. Test 2, correct answer 1. Test 3, correct answer 4. Test 4, correct answer 5. Test 5, correct answer 2. Test 6, correct answer 4. Test 7, correct answer 2. Test 8, correct answer 2. And test 9, correct answer 3. All explanation you saw and the text, I don't want to stop on it because today we will have a very long, very interesting but quite difficult topic, and I don't want to waste time for answers. You can discuss it with each other or ask us in a comments in a Facebook. But now I want to start our today's lecture. It is diseases of hypothalamic-pituitary system. And for today, I have several tests for you too. First test. 42-year-old man presents to a new family physician to establish care. According to the patient, he has been healthy his entire life and rarely visits doctors. Although he recently got married and his wife insisted to see a doctor at least once. He reports no past medical or surgical history. His physical exam is notable for elevated blood pressure, 150 by 90 millimeters hydrochloride, and the findings seen in figure. You see a general habitus of this patient and his face. What will be the most likely cause of death for this patient? First, it is respiratory disease. Second, cardiovascular disease. Third, malignancy. Fourth, chronic kidney disease. And fifth, liver failure. If you don't know just now the answer of this question, please be very attentive during lecture, because in this lecture I will answer all these questions. Plan of our today's lecture. It is to give definition for disease of hypothalamic-pituitary system, to discuss epidemiology, risk factors, etiology, mechanisms, classification, clinical presentation, diagnosis, treatment, prognosis, and prophylaxis of diseases of hypothalamic-pituitary system. Before definition, I hope you remember that hypothalamus and pituitary form a functionally integrated complex. They working in complex influence to on each other and regulate each other. What is the diseases of hypothalamic-pituitary system? It is the damage of hypothalamic-pituitary system can impact the responsiveness and normal functioning of the pituitary and may cause inhibited signaling to the pituitary or decreased functioning of the pituitary, leading to deficiencies of one or more of following hormones. What hormones? Please remember from physiology: anterior pituitary. It is the thyroid-stimulating hormone or TSH, adrenocorticotropic hormone ACTH, beta-endorphin, luteinizing hormone or LH, follicle-stimulating hormone FSH, prolactin, and melanocyte-stimulating hormones on MSH. Damage to hypothalamic-pituitary system may too cause excess pituitary hormone secretion, both of them as deficiency as excess secretion. Here you see the breakdown of disease distribution. Pituitary adenomas and craniopharyngiomas are the most common lesions inherited. And here in the scheme you see that most often it is Cushing's. On second place are non-functional adenomas, and nearly twice more rare it is craniopharyngiomas, and other much more rare disturbances, other conditions and deficiencies or excessive secretion of other hormones. And here a pie chart demonstrating the distribution by age of patients with pituitary tumors. You see that more than half of patients are in age from 26 to 45. It is middle-aged adults. A little bit more rare it is patients after 46 and younger than 25, but more than 14. And just 5% of case it is children less than 13 years old and aged people more than 61. Here classification according to international classification of disease. Here you see diagnostic codes of all hypothalamic-pituitary disorders. And risk factors of diseases of hypothalamic-pituitary system. What it can be? It is anorexia, bleeding, bulimia, genetic disorders, growth or tumors, and head trauma. Here you see very interesting photo. It is unique because here in one moment it is makes photo of the highest and the lowest person in the world. It is He Ping from China and Sultan Kosein from Turkey. More of its risk factors can be infections and swelling due to inflammation. It is malnutrition, radiation, surgery, and hyperironemia. Mechanisms. I hope you remember regulations of anterior hypothalamo-anterior pituitary link, yes, and relation of hormone secretion between them. Commonly, hormone deficiencies may include gonadotropin deficiency that involves LH and FSH affecting the reproductive system in men and women, and menstruation in women. It is TSH deficiency leads to hypothyroidism. You remember from previous lecture, it is central hypothyroidism. It is ACTH deficiency leads to a reduction in secretion of adrenal hormones resulting in hypoadrenalism. It is the last lecture, hope you remember too. It is central Addisonian disease. Growth hormone deficiency has a variety of different negative effects at different ages. Like an example, in newborn infants may be hypoglycemia or micropenis, while in later infancy and childhood growth failure is more likely. Other hormone deficiency, it is prolactin deficiency leads to diabetes insipidus. It is very rare situation, but possible. It can be multiple hormone deficiency. It is deficiency of single, usually it starts from single pituitary hormone. Generally, the most often growth hormone is lost first, then it is luteinizing hormone deficiency follows. Loss of FSH, TSH, and ACTH follow much later. The progressive loss of pituitary hormone secretion is a slow process which can occur over a period of months or years. Panhypopituitarism or pituitary failure represents the loss of all hormones released by the anterior pituitary gland. Here you see a photo of pituitary tumors that can produce excess hormone, or they can block hormone production, or they can be non-functioning. It means that it not affects no increase, no decrease hormone levels, no affect hormone level at all. According to International Classification of Disease, we code it in E00 to E90 in endocrine, nutritional, and metabolic diseases. And you see codes of pituitary disorders. Clinical classification, that is the most useful for us in our practice. First, it is pituitary adenomas. Here we means like tumor for its mechanical influence, like some tumor in central nervous system, and it is effects. What effects we will discuss. Next syndrome, it is hypopituitarism. According to what hormone is affected, it can be somatotropin or growth hormone deficiency, gonadotropin deficiency, corticotropin deficiency, thyrotropin deficiency. Or opposite situation, it can be excess pituitary hormone secretion. It can be prolactinomas, acromegaly, Cushing disease, thyrotropin secreting adenoma. Another forms of pituitary disorders, it is non-functional and glycoprotein secreting pituitary adenomas. It can be lymphocytic hypophysitis, it can be empty cellular pituitary apoplexy, and diabetes insipidus. All these forms we will discuss during our lecture. And before it, let's discuss in general symptoms of it. The partial list of tumor symptoms like mechanical influence, it is headaches and loss of vision. Partial list of hypothyroidism symptoms for central. I said you in lecture about thyroid gland that central, primary and secondary central hypothyroidism, they clinically the same. That's why symptoms like in usual primary hypothyroidism. It is cold intolerance, constipation, depressed mood, fatigue, hair and skin changes, hoarseness, impotence, loss of body hair and muscle, especially in men, mental slowing, menstrual cycle changes, and weight gain. Partial list of low adrenal function, it is dizziness, weakness. Remember that Addison is very non-specific symptoms. Partial list of other symptoms, it is body temperature problems, emotional problems, excess thirst, obesity, uncontrolled urination, Kallman's syndrome. It is type of hypothalamic dysfunction that occurs in men. Symptoms of it is lowered function of sexual hormones, we name it hypogonadism, and inability to smell. One more time, schematically signs and symptoms. And partially signs and symptoms of brain tumor. It is a very usual scheme, even not for medics, how to determine a brain tumor. And the most specific symptoms for brain tumor to suspect it is vomiting, mood swings, cognitive decline, hearing problems, headaches, speech problems, and seizures. And next steps, test for today. A 67-year-old female presents with a complaints of fatigue, nausea, and headache that have developed over the past several weeks. Her past medical history is significant for hypertension, diabetes mellitus, chronic heart failure, and small cell lung cancer diagnosed and treated 3 years previously. Vital signs are as follows: temperature 37.3, heart rate 82, blood pressure 142/86, respiratory rate 16, saturation 97 on room air. On physical examination, peripheral edema is absent, and she is alert and oriented to person, place, and time. Abnormalities noted on initial lab work include glucose 138 milligrams per deciliter and sodium 122. Follow-up testing reveals urine osmolarity of 310 and serum osmolarity 268. Bun and creatinine levels are within normal limits. Which of the following is the best next step in management of these patients? First option, it is demeloxicline administration. Second, initiate dermopricin nasal spray. Third, fluid restriction. Fourth, hypertonic saline infusion. Fifth, lithium carbonate administration. If you don't know it, please listen our further lecture. Pituitary tumors. Yes, what is the mechanical influence of pituitary tumors? Pituitary adenomas, it is the most often situation of pituitary tumors. We can divide it in microadenomas less than 10 mm and macroadenomas more than 10 mm. Arise from adenohypophyseal cells and are almost always benign. Pituitary adenomas discovered by CT or MRI examination, in the absence of any symptoms or clinical findings, are referred to as pituitary incidentalomas. Pituitary adenomas are rarely associated with parathyroid and neuroendocrine hyperplasia or neoplasia as a part of multiple endocrine neoplasia type 1 or MEN1 syndrome. Pituitary carcinomas are extremely rare, but metastases from other solid malignancies, mainly breast and lung, can occur. Signs and symptoms of pituitary tumors. Pituitary tumors can manifest with signs and symptoms of pituitary hypofunction, hormone hypersecretion, or mass effect. Impigmentation of the chiasma by pituitary tumor. Impingement of chiasma by the pituitary tumor results in visual field defects, most commonly bitemporal hemianopia. Patients with cellular mass pressing on the optic chiasma should have a Humphrey visual field test. Lateral extension of pituitary mass of the cavernous sinuses can result in diplopia, ptosis, or altered facial sensation. There is no specific headache pattern associated with pituitary tumors, and in some patients the headache is unrelated to pituitary adenoma. Here is explanation why we have such symptoms in pituitary tumors. You see anatomy of pituitary, and it plays just under the chiasma. And impingement of the chiasma by pituitary tumors results in visual field defects. Most common it is bitemporal hemianopia, or it is losing of lateral visual fields of both eyes. Diagnosis and treatment of pituitary tumors. MRI is the best method of visualizing of hypothalamic-pituitary anatomy. Like for all other tissue structures, I told you about it. Once a pituitary adenoma is found, it is necessary to determine its type. It is secretory or non-secretory, pituitary function, and whenever there is any visual field defect. The treatment includes reduction or complete removal of the tumor, elimination of mass effect, normalization of hormone hypersecretion, and restoration of normal pituitary function. Some patients with large tumors require additional medical and radiation therapies. The most important factor is pituitary surgery is the availability of an experienced neurosurgeon. Here you see a picture of large non-functioning pituitary adenoma disclosed in patient with macroprolactinemia. It's shown by arrows. And next step for today. Next test. 34-year-old man with history of major depressive disorder presents to the emergency room with altered mental status. Vital signs are stable, and he appears euvolemic on exam. Serum sodium is 120. The patient's hyponatremia is attributed to newly prescribed fluoxetine. Which of the following is another cause of euvolemic hyponatremia? First, it is congestive heart failure. Second, nephrosis. Third, prerenal acute kidney injury. fourth, mineralocorticoid deficiency, and fifth, lung malignancy. Pituitary adenomas are the most common cause of hypopituitarism. That is the next disorder for today. But other causes include paracellular disease, pituitary surgery, radiation therapy, inflammatory and granulomatous disease, and head injury. The subsequent sequential loss of pituitary hormone secondary to a mass effect is in the following order. I told you about this order. It is growth hormone, LH, FSH, TSH, ACTH, and prolactin. Etiology of hypopituitarism lying in isolated deficiency of various anterior pituitary hormones can occur. In general, pituitary microadenomas are rarely associated with hypopituitarism. Diabetes insipidus is almost never seen in patients with pituitary adenomas at presentation. And isolated deficiency of different hormones, first of it is somatotropin or growth hormone deficiency. Growth hormone deficiency is premenopausal woman is recognized earlier on account of amenorrhea, infertility, and loss of libido. Men often delay presentation on developing impotence or loss of libido. Through this wider recognition of effective management of erectile dysfunction, this pattern is reversing, provided other practitioners check for hormonal causes. Patients with growth hormone deficiency have increased body fat and decreased lean body mass, and they might have decreased bone mineral density. Growth hormone deficiency is evaluated by dynamic testing, including the insulin tolerance test and growth hormone releasing hormone 2-arginine test. Here you see that growth hormone, also known as somatotropin, in childhood first of all affected the height of the patient, and its action during childhood, if it is too much growth hormone, it can lead to very high height, and deficiency of growth hormone can lead to very low height. You remember photo. Both of those people had somatotropin problems. Gonadotropin deficiency. It is another hormone deficiency, or another name of this state. It is hypogonadism. In a woman, hypogonadism causes infertility and oligomenorrhea or amenorrhea, often associated with lack of libido, hot flushes, and dyspareunia. In men, hypogonadism is diagnosed less often because decreased libido and impotence may be considered functions of aging. Osteopenia is a consequence of long-standing hypogonadism and response to hormone replacement therapy. Hypogonadism is diagnosed in the presence of low or normal LH and FSH levels in women or in men with testosterone levels less than 200 nanograms per deciliter. Estrogen replacement is necessary in women to prevent osteoporosis and to treat hot flushes, decreased libido, and vaginal dryness. Testosterone in men may be replaced by intramuscular injection, transdermal patch, or gel. Oral testosterone is not recommended. Here you see typical view of patients with hypogonadism. You see it is lack of vocal change, it is narrow shoulders, it is absence of facial and body hair, it is decreased muscle mass, especially on extremities, it is gynecomastia or increased breast glands. It is long arms and legs, it is wide hips, and underdeveloped genitalias and female pubic hair pattern. And on the right you see a photo of real patients with hypogonadism with all these symptoms. Next, it is corticotropin or ACTH, adrenocorticotropic hormone deficiency. Patients with ACTH deficiency maintain mineralocorticoid secretion. I hope you remember from previous lecture, because aldosterone is regulated primarily by renin-angiotensin system and serum potassium concentration, but not from pituitary and hypothalamus. Symptoms include chronic malaise, fatigue, anorexia, low-grade fever, hypoglycemia, and less often hyponatremia. An ACTH stimulation test and early morning at 8 a.m. plasma cortisol level measurement are initial tests. Cortisol level less than 3 confirms adrenal insufficiency. Level more than 15 makes diagnosis unlikely, and levels in the intermediate range demand additional cosintropin stimulation test. I showed you all it in previous lecture. Hydrocortisone replacement is necessary in doses 15-20 mg per day, with the highest one given in the morning. In case of an acute distress, patterns should be instructed to carry a medical alert and double replacement dosage for 2 or 3 days. Next type of deficiency, it is thyrotropin or TSH deficiency. TSH deficiency are similar to those in patients with primary hypothyroidism, including malaise, fatigue, leg cramps, dry skin, and cold intolerance. I told you a lot of different symptoms, a lot of information in thyroid lectures, and a clinic of central hypothyroidism will be the same with primary thyroid hypothyroidism. The diagnosis can't be established only through the measurement of TSH, like for primary, because these patients might have a normal TSH level. If secondary hypothyroidism is clinically suspected, TSH and free thyroxine or T4 should be measured together. Usually patients have low or normal TSH level along with low free T4 level. Therapy for TSH deficiency is similar to that for primary hyperaldosteronism. It is a levothyroxine replacement. The dose of it should be adjusted according to the patient's clinical status and free T4 and free 3-iod-thyronine or T3 levels, but not according to TSH. From previous slide, you know why. If TSH deficiency or secondary hypothyroidism is clinically suspected, TSH and free T4 should be measured together. One more time, usually patients have low or normal TSH level along with low free T4 level. It is criteria for central or secondary hypothyroidism. Now we start excess pituitary hormone secretion. It is the opposite situation with overproduction of pituitary hormones. And first and most often problem, it is prolactinoma. Clinical features of it. Prolactinomas are pituitary adenomas that secrete prolactin in varying degrees and account for about 30% of all pituitary adenomas. It is very often pituitary problem. Prolactinomas are more common in women with a peak incidence during the childbirth years. Clinical features related to excess prolactin. Women of reproductive age mainly present with oligomenorrhea, amenorrhea, galactorrhea, or infertility. Men and postmenopausal women usually come to medical attention because of mass effect, such as headaches and visual field effects. The majority of patients with a serum prolactin level more than 100 have prolactinoma. A serum prolactin less than 100 in the presence of large pituitary adenoma suggests stuck compression. For diagnosis, we use the same methodic, that is visualization, and here it is a picture of microprolactinoma in patients with primary hypothyroidism. You see this microprolactinoma by arrow. This condition should be considered whenever prolactin levels remain elevated following normalization of TSH and free T4. Here are the photo of microprolactinoma in patient with macroprolactinemia by arrow. After PEG precipitation, prolactin recovery was low, nearly 25%, but prolactin levels remain elevated. Here you see a CT scan of giant invasive pituitary prolactinoma with falsely low serum prolactin 103 due to hook effect or mass effect. Prolactin levels rose to 13,000 after a 1 to 100 serum sample dilution. Here is a photo of tomography of patients with diffuse pituitary enlargement with primary hypothyroidism-induced hyperprolactinemia before on first picture A and after picture B L-thyroxine replacement. You see the reduction of the tumor in the base of levothyroxine replacement. Treatment of prolactinomas. Dopamine agonists are therapy of choice for most patients, and they are effective in decreasing adenoma size and restoring normal prolactin level. The most common side effects include nausea, headache, dizziness, nasal congestion, and constipations. Cabergoline and bromocriptine are potent inhibitors of prolactin secretion and often cause tumors shrinkage. Cabergoline is more potent and may be taken only twice a week. Surgery is reserved for patients who are intolerant or refractory to medical therapy. Radiation therapy may be considered for patients who poorly tolerate dopamine agonists and can't be cured by surgery. Next disorder for today, it is acromegaly. What clinical features we can see? Acromegaly, it is a rare disease caused by growth hormone secreting pituitary adenoma in more than 99% of patients. Excess growth hormone before the fusion of the epiphyseal growth plates results in gigantism. Clinical features include arthralgias, neuropathic carpal tunnel syndrome, coarsening of facial features, excessive sweating, goiter, hypertension, heart failure, arrhythmias, impaired glucose tolerance, macroglossia, tooth gaps, pituitary mass effect and insufficiency, sensory and motor peripheral neuropathy, sleep apnea, etc. Acromegalic patients carry an increased risk of malignancy such as premalignant adenomatous, colon polyps, and colon cancer. Random growth hormone levels are associated with increased morbidity and mortality if untreated. The most commonly noticed symptom is abnormal enlargement of hands and feet. Enlargement of the feet may require increasingly larger shoe size, like on these pictures. Changes in facial features can include enlargement of forehead and jaw with pronounced underbite, spreading teeth, and enlarging tongue. The nose and lips may enlarge as well. Treatment of acromegaly. The goal of therapy for most patients is to achieve a normal sex and age-adjusted IGF-1 and growth hormone less than 2 nanograms per milliliter. Surgery is the treatment of choice even if a cure can't be achieved. Even a subtotal resection of a tumor will improve the efficiency of subsequent adjuvant therapy. Somatostatin analogs inhibit growth hormone secretion mainly by binding to somatostatin receptors and result in normalization of IGF-1 in up to 65% of patients. Pegvisomant has higher affinity to growth hormone receptors than native growth hormone, but inhibits its dimerization, which is necessary for the action of growth hormone. Dopamine agonists have variable efficacy but may be an attractive first-line therapy, especially in those with co-secretion of prolactin and growth hormone. Next disorder, it is Cushing disease. You remember our previous lecture, it was Cushing syndrome, and it formed ACTH dependent or central Cushing or Cushing disease. Symptoms of it. First of all, Cushing disease comprises symptoms and signs associated with prolonged exposure of inappropriately high levels of plasma ICTH-dependent free glucocorticosteroids. The stria in Cushing syndrome are usually red-purple, more than 1 cm wide, and located off abdomen, upper thighs, breasts, and arms. Increased skin pigmentation is rare and only occurs in the ectopic ACTH syndrome. Supraclavicular and dorsocervical fat pads or buffalo hump and moon face are non-specific and seen in many patients of obesity clinics. Women complain of menstrual irregularity, nearly 84% of all patients, and hirsutism, especially vellus hypertrichosis of face. Men and women exhibit loss of libido, nearly 100%, nearly all patients. Psychiatric abnormalities occur in half of patients. One more time, clinical features of Cushing disease. It is central obesity, unexplained osteoporosis, proximal myopathy, white pearlish stria more than 1 cm, facial plethora, spontaneous bruising, hypokalemia, and serial photographs. And you saw this scheme in previous lecture. It is the disorders of ACTH-dependent Cushing syndrome and ACTH-independent. And for our today's topic, it is ACTH-dependent. More than 67% of all cases, it is Cushing disease, of all Cushing syndrome at all. It is a photo of patient with Cushing disease, and here you can see red pearlish abdominal stria, 1 cm in wide. Here we can see on abdomen in typical place for the stria. It is a general view of female patient with Cushing disease schematically, and add the photo with typical Cushing symptoms. It is moon face, it is flat cheeks, fat pads or buffalo hump, it is high blood pressure, bruising, thin skin, red stria, pendulous abdomen, poor wound healing, thin arms and legs. Scheme of differential diagnosis for Cushing disease. It is from previous lecture too. Hope you remember it from there. And treatment of Cushing disease. Surgical removal of ACTH-secreting pituitary tumor is the treatment of choice, of course. Availability of experienced neurosurgeon is crucial for long-term remission rate is about 60 to 80% following surgery. A low, less than 3 or undetectable post-operative cortisol level of glucocorticosteroids is considered to be a good marker of long-term cure. Other options include reoperation and radiotherapy. Bilateral adrenalectomy is reserved for those who continue to be hypercortisolenemic. Medical therapy like ketoconazole has limited value because of associated toxicity and gradual decrease in efficiency. During therapy, liver function tests need to be closely monitored. And next disorder, it is thyrotropin secreting adenoma. TSH-secreting pituitary adenomas account less than 1%. It's quite rare disorder of all pituitary tumors and at mean age 40 years with a slight female predominance. Symptoms secondary to hyperthyroidism and goiter are the initial complaints if the disease remains undiagnosed. The most important feature is elevation of serum T4 and T3 levels with inappropriately normal or elevated TSH level only shortly before surgery. patients with TSH-secreting adenomas, surgery is the primary therapeutic approach. Radiation is generally used for those with residual tumor. Somatostatin analogs are effective for control of excess TSH production, leading possibly to a decrease in tumor size. Beta blockers should be initiated in uncontrolled hyperthyroidism. Antithyroid medications may be used only shortly before surgery. Next, it is non-functional and glycoprotein-secreting pituitary adenomas. Non-functional and glycoprotein-secreting pituitary tumors account for about 25 to 30% of all pituitary adenomas. It is on second place after prolactinomas in all structure of pituitary tumors. Many clinical and non-functional pituitary adenomas are glycoprotein-producing tumors and usually manifest with clinical features related to mass effect, including visual field defect, hypopituitarism, and headache. The standard treatment for patients with mass effect is surgery, mainly through the transsphenoidal approach. Radiotherapy is indicated in patients with residual pituitary tumors following surgical debulking or in those who are not surgical candidates. The use of high-dose dopamine agonists has been associated with a decrease of tumor size in only 10% of all patients. Next disease for today is lymphocytic hypophysitis. Lymphocytic hypophysitis, it is a rare autoimmune inflammatory lesion of the pituitary gland, commonly affecting young women during late pregnancy or in the postpartum period. Lymphocytic hypophysitis is associated with other autoimmune disorders, mainly Hashimoto's thyroiditis and Addison's disease. The clinical manifestations relate to mass effect or hypopituitarism. The corticotropin axis is the most commonly affected axis. The chronological association with pregnancy or the postpartum period and isolated ACTH deficiency is diagnostic clue. Transsphenoidal surgery is the therapy of choice for patients with pituitary mass effect, as usual. It is important to monitor patients with varying degrees of hypopituitarism because some have recovery on their pituitary axis. Another disorders, it is empty cella. The empty cella is defined as a cella that, regardless of its size, is completely or partly filled with cerebrospinal fluid. An empty cella of normal size is a common incidental autopsy finding. The empty cella is called secondary when it is seen after surgery, irradiation, or medical treatment for a pituitary pathology. Most patients have no pituitary dysfunction, but partial or complete pituitary insufficiency has been reported. The discovery of an empty cella needs to be followed by endocrine evaluation to determine whether there is any associated pituitary dysfunction. Management usually involves reassurance and hormone replacement if necessary. Here visualization, it is the photo where the empty cella is defined as cella that, regardless of its size, completely or partly filled with cerebrospinal fluid, and you see it on these pictures. Another disorder, it is pituitary apoplexy. Pituitary apoplexy is a rare endocrine emergency resulting from hemorrhagic infarction or pre-exciting pituitary tumor. The clinical manifestations are related to rapid expansion of the tumor secondary to hemorrhage with compression of the pituitary gland and the pericellular structures, leading to headache, hypopituitarism, visual field defect, and cranial nerve pulses. Headache is the most prominent symptom in most patients with clinically evident pituitary apoplexy. Once pituitary apoplexy is suspected, stress-dose glucocorticosteroids like dexamethasone 4 mg every 8 hours IV should be initiated and pituitary MRI should be performed. Patients with mass effect benefit from tumor and blood clot debuckling, which leads to resolution of visual field defects and improvement of cranial nerve pulses in most patients. And it is a visualization of pituitary apoplexy. And last disorder for today that I want to discuss with you, it is diabetes insipidus. What are the types of it and what clinical symptoms of it? Diabetes insipidus is characterized by chronic exertion of abnormally large volumes, more than 50 milliliters per kilogram of dilute urine. Diabetes insipidus is usually underdiagnosed because the symptoms and signs are benign and many patients ignore them or are unaware of them. There are 4 major types of diabetes insipidus: central neurogenic diabetes insipidus, nephrogenic diabetes insipidus, primary polydipsia, and gestational diabetes insipidus. Central diabetes insipidus is secondary to inadequate antidiuretic hormone or vasopressin secretion. It results in few symptoms including polydipsia and polyuria. Nocturia is a large urine volume is often the primary reason of which patients seek medical attention. Diabetes insipidus is not associated with any abnormality on the physical examination or routine laboratory evaluation, except of low urine osmolarity. Diagnosis. Once diabetes mellitus and hypercalcemia have been excluded, patients should have 24-hour urinary volume measurement during ad libitum fluid intake. Diabetes insipidus is diagnosed in those with urinary output more than 50 milliliters per kilogram per day. Urinary osmolarity less than 300 milliosmoles per kilogram and creatinine excretion from 14 to 18 milligrams per kilogram body weight as an indicator of an accurate 24 hours urine collection. Measurement of spot urine osmolarity is unreliable to exclude or diagnose diabetes insipidus because it may be decreased significantly in an otherwise healthy person who drinks large amounts of water. Patients with diabetes insipidus who are conscious usually have sufficient thirst to maintain a normal serum sodium level in spite of polyuria. Once the diagnosis has been established, the next step is to differentiate the type of diabetes insipidus. A water deprivation test may need to be performed by an experienced endocrinologist to differentiate among types of partial diabetes insipidus. Here differential diagnosis of different types of diabetes insipidus according to urine osmolarity after fluid deprivation and after desmopressin. And according to what level of osmolarity you can determine is it neurogenic, nephrogenic, primary polydipsia or partial diabetes insipidus. And it is scheme of correlation of plasma arginine vasopressin with plasma osmolarity in normal subjects, in part of who have central pituitary diabetes insipidus and in those who have nephrogenic diabetes insipidus. Therapy. The treatment of choice for central diabetes insipidus is intranasal synthetic replacement for vasopressin or desmopressin acetate at doses of 5 to 20 micrograms daily. Central diabetes insipidus has responded to chlorpropamide with 25 to 75% reduction in polyuria. Oral repletion of water often is sufficient to reverse acute dehydration in diabetes insipidus. There are no effective pharmacological agents to treat a compulsive water drinker. A low osmolar, low sodium diet should be initiated to manage congenital nephrogenic diabetes insipidus. The therapy of choice for central diabetes insipidus is administration of antidiuretic hormone analog desmopressin. It is available in subcutaneous form or as an oral or nasal spray. The spray or oral form of desmopressin is usually started at bedtime and is gradually titrated for the desired antidiuretic effect. And one more test for you for today. A 45-year-old female undergoes a transphenoidal approach for pituitary prolactinoma. Surgery proceeded without complications and the entire mass was removed. The patient's urine output is 4 liters on post-operative day 1 and labs are significant for serum sodium of 145, normal from 135 to 145. Urine osmolarity is 185 and urine specific gravity is 1.004. It is decreased from normal. Which of the following choices is the next best step? First, it is water restriction. Second, loop diuretic. Third, CT scan of the brain. Fourth, 0.45% sodium chloride administered IV. And fifth, desmopressin. Prognosis and prophylaxis of pituitary and hypothalamic disorders. Many causes of hypothalamic dysfunction are treatable, and most of time missing hormones can be replaced. That's why there are most number of cases of pituitary disorders have a good prognosis, because all of them in case of diagnosing are treatable and hormones can be replaced. It is abbreviations of our today's lecture. For today, that's all. It's all what I want you to talk about hypothalamic-pituitary system disorders. In comments under the video, as usual, I'm waiting for your group numbers and names. And if it's interesting for you, please answer on questions during lectures. Write us in comments or for discussion in our Facebook page. And I wish you good luck, and you will continue your lectures according to schedule, but with another type, another fields of internal medicine. And next lecture, please wait, a first lecture about gastrointestinal disorders. And for today, that's all, and goodbye.